Good morning, everyone. Welcome to for today's clinical ground round from Department of Neurology. We have selected this case to discuss the critical issues faced on day-to-day basis in management and treatment. We will share the pain and pleasure associated with management of this challenging case using multidisciplinary approach. We will also illustrate how we handle the hurdles in the light of our departmental experiences. The case presentation will be done by Dr. Vishal, who was primarily involved in management of this patient. Issues faces during the management will be discussed by Dr. Sayam, Dr. Firoz, and Dr. Rupali subsequently in between the presentation. Finally, the conclusion will be laid down by Dr. Nagendra. Now, I inviting Dr. Vishal to start with case. Dr. Vishal.
Thank you, Dr. Prakashar, and a very good morning to all. Today, we'll be discussing the management of a 9-year-old boy who presented with chief complaints of rapidly progressive sensory motor quadriparesis of 10 days duration, palpitations and dryness of mouth of 3 days duration, and shortness of breath for the past 1 day. Patient was apparently doing well till 10 days back when he developed tingling sensation in all 4 limbs, which was continuous in nature and used to disturb his sleep. He did not have any complaints of burning sensation or pain. 5 days later, patient developed weakness, which was acute in onset, generalized, and ascending in nature, such that now the patient had difficulty in sitting without support. For the past 3 days, patient also had developed autonomic symptoms like palpitations, sweating, constipation, and dryness of mouth. And for the last 1 day, he complained of respiratory symptoms like shortness of breath and bulbar weakness. There was no history of neck pain, myalgia, or any fluctuation in the weakness. There was no history of any headache, altered sensorium, loss of consciousness, seizures at the time of admission. There was no history of any chest pain or syncope. Patient gave history of a short febrile episode about 4 weeks back, which had resolved spontaneously. This was not associated with any diarrhea or upper respiratory tract infection. There was no history of any dog bite, recent travel, or vaccination. In the past, patient used to have pain abdomen off and on, but did not require any treatment for this. In the personal and family history, there was no significant findings. To summarize, we had a young boy with rapidly progressive ascending sensory motor quadriparesis with respiratory, bulbar weakness, and autonomic symptoms. We considered a possibility of acute flaccid paralysis. The differential diagnosis of acute flaccid paralysis could be localized to the cord, like acute myelopathies, but they generally have got a definite sensory not present in our case. Considering anterior horn cell disease like poliovirus, they are also purely motor, and our patient had predominantly sensory complaints to begin. Neuromuscular junction disorders like myasthenia, they are also purely motor, and our patient had predominant sensory complaints. Later, he developed the motor weakness. Also, muscle disease is also purely motor. Hence, we were left with peripheral nerve disease. In that, GBS and porphyria were considered. There was no exposure to any heavy metals. Hence, toxic neuropathies was not primarily considered. Patient was admitted from our OPD. He had a heart rate of 80 per minute, which was fluctuating till 130 per minute. The heart rate had poor variability with respiration, suggesting an autonomic dysfunction. He had hypertension. His blood pressure was 150 by 90 millimeters of mercury. Respiratory rate was 24 per minute, and saturation was normal. His single breath count at the time of admission was 11. There was no pallor, icterus, cyanosis, or generalized lymphadenopathy. Rest of the systemic examination was normal. Patient was conscious, oriented, and cooperative. He had bilateral lateral rectus palsy on examination. He had element type bilateral facial palsy, and his palatal movements were reduced. He was wheelchair bound, hypotonic, and he had grade 3/5 power in his proximal limbs and 2/5 in his distal limbs. In the sensory examination, patient had impaired touch and vibration sensations distally, and his joint position sense was also impaired. The reflexes were absent, and his plantars were mute. We made a presumptive diagnosis of Guillain-Barre syndrome, most likely AIDP variant because of a sensory motor quadriparesis. Porphyria was also considered because of sensory motor quadriparesis, dysautonomia, and history of pain abdomens. A nerve conduction study was done at the time of admission, which revealed prolonged distal latencies, conduction blocks, and reduced conduction velocity in bilateral median motor and ulnar motor nerves. The peroneal nerves and other sensory nerves were non-recordable. This was suggestive of a demyelinating sensory motor polyneuropathy. A CSF analysis showed albuminocytological dissociation, and routine investigations showed polymorphonuclear leukocytosis, mild transaminitis, mild hyponatremia, and ECG revealed sinus tachycardia with poor heart rate variabilities. His chest X-ray was normal at the time of admission. Hence, the diagnosis of Guillain-Barre syndrome, AIDP variant, was confirmed. Patient also had involvement of his respiratory, bulbar, and autonomic symptoms. The question was where to admit this patient and whether he needed intubation. Our patient had bulbar weakness, respiratory weakness, and dysautonomia. So we admitted our patient in the ICU under a cardiac monitor and measured his vitals continuously. ABG was done, which was normal. The next question was whether he needed intubation at this stage. Our patient had bulbar weakness, respiratory weakness, and autonomic dysfunction. And as per the international GBS consensus guidelines, such patients need invasive ventilation and mechanical ventilation. Our department, with an experience of over 25 years in managing GBS patients, when there was economic constraints of the patients and there was limited availability of ventilators, used to intubate these patients only on the basis of their ABG criteria when they had hypoxemia, hypercarbia, or any acidosis on the ABG. And on analysis of about 100 patients of GBS who had respiratory compromise, the outcome was measured, and we saw that conservative intubation did not increase their mortality. Also, if we were intubating these patients on the basis of ABG and not just on the basis of their respiratory symptoms or bulbar weakness, we could avoid intubation in more than 50% of these patients. Here we can see that the patients who were not mechanically ventilated had lesser number of complications and their hospitalization was shorter. Patient was constantly monitored. His single breath count was charted and patient was kept on a Riles tube feeding because of the bulbar weakness. Other supportive measures were also given. A ventilator was kept on a standby should the patient deteriorate. Now, how to monitor such patients of GBS who have got respiratory and bulbar weakness who have not been intubated? Frequent ABGs are not practical in these patients. Here comes the role of single breath count. Our department devised an innovative method to objectively measure the single breath counts using the 2 Hz click using the auditory evoked potential machine. In this video, which is for illustration, this is the patient who is a case of GBS, recently discharged from our ward. He also had got a single breath count of 11, being monitored by a single breath count using an audio file which has been given to the attendant. The patient is made to sit up and count along with the clicks of the audio. And the maximum he can count in one breath is noted down every hour. Serial single breath count as a reliable tool for monitoring respiratory functions in GBS. We saw that the single breath count correlated very well with the ABG parameters. All the patients maintained a desired ABG without any respiratory distress up to a single breath count of 7. At single breath count of 5, the need for mechanical ventilation could be predicted with a sensitivity of 90% and a specificity of around 95%. Hence, in patients till an SBC of 7, repeated ABG may be avoidable in patients with GBS. Here we can see that up to a single breath count of 7, there were no derangement in the ABG parameters, and only beyond that, the ABG were deranged and the patient needed intubation. Hence, a single breath count of less than 7 was correlating with the deranged ABG. Another study looking at the primary outcome of mechanical ventilation in these patients with using the single breath count, and we compared the single breath count with the other models to predict the mechanical ventilation in these patients. Here we can see 2 ROC curves. On the left side is the ROC curve for the EGRIS score and the Shachar score. For reference, EGRIS score takes into consideration the days from onset of weakness to hospitalization, the facial or bulbar weakness, and the motor weakness. And we compared this score to the single breath count and found that the ROC curve was almost similar and in fact slightly better than this model to predict mechanical ventilation. So what is the specific treatment of GBS? IVIG at a dose of 400 milligrams per kg per day for 5 days, or plasmapheresis at a dose of 40 to 50 ml per kg per day for 5 sessions. We treated our patient with IVIG. However, overnight patient had further drop in his single breath count over 50%. Patient developed tachycardia and fluctuations in his heart rate. He had hypertension and his ABG showed increasing PCO2 levels. Here we intubated our patient and patient was started on mechanical ventilation. We continued the IVIG at this time, but we observed that patient had developed altered sensorium. He was not following commands, and during the rounds, patient was observed to have seizure. This is the video taken during the time the patient seizure. You can see that the patient has got jerky movement right side of his body, uprolling of eyeballs and unresponsive.
Yes, sir.
Patient was managed with injection lorazepam, and we gave short-acting beta blockers to control his dysautonomia. We optimized his ventilatory settings, and investigations were sent which showed further increase in his TLC count. His sodium was still low, other electrolytes were normal. So here we had a dilemma, whether this was an IVIG reaction because patient was on IVIG overnight and he had developed these symptoms after that. How safe or unsafe is IVIG? And whether stopping the IVIG, we are doing any harm because the patient is not receiving the treatment which has been advised. To discuss about IVIG, I'll invite Dr. Sayyam to come up on the stage, please.
Thank you, Dr. Vishal. Good morning, everyone. Here we had a 9-year-old boy with GBS AIDP who, after starting IVIG, developed an episode of seizure with altered sensorium. So what are the common complications of IVIG therapy? The adverse reactions of IVIG can be divided into 2 groups, immediate and delayed. Immediate can be further subdivided into mild, moderate, and severe. Mild adverse reaction is one which causes minimal discomfort to the patient, and treatment involves either slowing the infusion or patient being given NSAIDs. Moderate adverse reaction are those which require infusion discontinuation and antihistaminics or NSAIDs to be administered. Severe adverse reaction are those which require infusion to be stopped immediately and corresponding medical attention to be provided. Delayed adverse reaction are those which occur within hours to days after starting an IVIG. Amongst the various systems that can be involved with IVIG therapy complications, in our patient pertaining to the neurological complications, we can have headache, aseptic meningitis, press, seizure, or stroke. Seizure is a very rare complication of IVIG therapy, and the possible cause is either SIADH or aseptic meningitis induced by IVIG, resulting in seizure. Coming to the GBS subtypes, depending upon the pattern of symptoms, we can have AIDP, AMAN, AMSAN, Bicasta brainstem encephalitis, Miller-Fisher syndrome, pharyngeal cervical brachial variant, and sensory ataxic variant. These different subtypes have different etiologies. In AIDP, the immunological attack occurs at the myelin sheath, resulting in demyelination, while in AMAN, the immunological attack occurs at the nodes of Ranvier, resulting in axonal degeneration. If we compare the treatment given, whether that is IVIG versus plasmapheresis, international trials have found that there is no significant difference in the outcomes. This led to the endorsed treatment option of either plasmapheresis or IVIG, in which IVIG is preferred in view of ease of administration and it being more widely available. When we compare the various treatment trials of GBS, we see that there are no major IVIG versus placebo randomized control trial. So we saw that the pathophysiology of different subtypes of GBS is different. However, the treatment recommended is the same. Is IVIG equally effective in all subtypes? And IVIG versus placebo, there are no comparison trials. Ethically, it is not possible as of now, as recommendation of IVIG in moderately disabled GBS is there. So to tackle this issue, our department conducted a retrospective study on a cohort of 528 patients, where we compared IVIG treated patients with natural course patients. The natural course patients were aged and peak disability matched patients who had not received IVIG or plasmapheresis or steroids. The peak disability in this trial was measured in GBS disability scale. So here we have 528 patients in our registry. Out of these, we selected 491 patients. Out of this 491, 203 received IVIG, 10 plasmapheresis, and 7 plasmapheresis with dexamethasone. Amongst the 203 patients with IVIG, we selected a group of 189 patients. And amongst the natural course patient of 271, we selected 199 peak disability and age match group. The baseline characteristics in these 2 groups was similar, and AIDP was the most common electrodiagnostic subtype. The primary outcome in this trial was functional disability at 6 months. In the results, we found that the outcomes at the 3 and 6 months were similar in both the IVIG and the natural course group. Comparing the Kaplan-Meier plot, we found that there was no significant difference in the cumulative probability of poor outcome over 180 days. In the subgroup analysis, we found that AIDP had a better recovery at 6 months with IVIG, but this benefit was not observed in AMAN patients. Thus, IVIG improves recovery of patients with AIDP, but similar efficacy was not observed in AMAN patients. Thus, customized use of IVIG based on subtypes is the key. Our patient who had AIDP would have benefited from IVIG, but IVIG had to be stopped in view of adverse reaction. But however, still everything is still not lost, and what will be his future outcome will be discussed by Dr. Vishal.
Thank you, Dr. Sayam, for enumerating all the possible role of IVIG in GBS. So our patient had seizures. In GBS, we don't usually expect seizure to occur. The cause that we considered were low sodium, but 133 was not low enough to cause seizure independently. He had probably an aseptic meningitis due to the reaction of IVIG, which we considered at this time. CVST and stroke due to hyperviscosity of IVIG was also considered, but there was no evidence of any thrombosis or stroke on the MRI or MR venography. Porphyria was also considered at this time because of the autonomic dysfunction, seizures, and altered sensorium. His urine porphobilinogen was sent, which was negative. Patient did not have any hypoxemia as he was already intubated and his ABGs and saturations were normal. He had dysautonomia, but there was no hypoxia or any hypotension. So this also was not a possibility to cause seizure. We stopped the IVIG, gave him injection methylprednisolone considering an allergy to IVIG infusion. The sodium was corrected by salt and saline, and we avoided all the drugs which are contraindicated in porphyria. We gave injection levetiracetam for his seizures. The boy thereafter remained encephalopathic for 3 days. He had persistent dysautonomia and having high blood pressures. Here we considered whether we were dealing with any other possibility, like hypertensive encephalopathy because of the high blood pressures and seizures. We did a MRI and MR venography, but the MRI did not show any evidence of PRES. Porphyria was still a possibility, and we repeatedly sent his urine porphobilinogen screen, which came out to be negative every time. We continued with levetiracetam and antibiotics like ceftriaxone and amikacin. His dysautonomia continued, and patients continued to have hypertension, requiring antihypertensives to be introduced. Initially, we gave beta blockers, but this also could not control his blood pressure. We had to add alpha blocker like prazosin, and we took opinion from endocrinology and nephrology to work out any secondary cause, but none were found. In this graph, we can see how his blood pressure remained high for the initial half of his illness. He had BP touching 180 systolic, which lasted till about 6th week, requiring initially the beta blockers. Then we had to add prazosin and gradually increase the dose up to the 5th or 6th week. Thereafter, his blood pressures got controlled, and we could gradually taper off his antihypertensives. Patient thereafter was observed to have persistent hyponatremia despite the correction that we were given. Other investigations showed high urine output and high urine sodium. So what could be the possible cause of persistent hyponatremia and polyuria in this patient? For this, I'll request Dr. Feroz to describe.
I'll be further discussing hyponatremia in this critically ill patient. As we know, hyponatremia in the critical care patient is the commonest electrolyte abnormality. It is associated with increased ICU mortality, prolonged ICU stay, and increased morbidity. Along with the hyponatremia, this boy also had high urinary sodium level, polyuria, and negative fluid balance, as if he is having salt wasting syndrome. This type of hyponatremia is commonly seen in CNS disorders, but less likely in GB syndrome. We mostly observed this type of hyponatremia in stroke, encephalitis, meningitis, subarachnoid hemorrhage, and subdural hemorrhages. Our department has significant work in this field. In a study of 100 stroke patients, we found 43% of the patients had hyponatremia, and the cerebral salt wasting was the commonest cause of hyponatremia. On further analysis, we found that hyponatremia was significantly correlated with prolonged hospital stay, increased comorbidities, low GCS score, and increased systemic inflammatory response syndrome. Similarly, in acute encephalitis syndrome, We also found hyponatremia in 27.8% of the patient and was more associated with neurologic cause of acute encephalitis syndrome compared to systemic causes. And it was also associated with prolonged hospitalization. Hyponatremia in tuberculous meningitis is the major problem. In a study of 76 tuberculous meningitis patients, we found hyponatremia in 34 patients, out of which 50% had cerebral salt wasting syndrome. And therefore, we did an interventional trial study that was published in a reputed journal. In this study, we randomized patient of tuberculous meningitis with CSW in 2 arms. Both the arms had received oral salt and saline, and another group had also received additional fludrocortisone. In this study, we found that patient treated with fludrocortisone normalized serum sodium level in 4 days, which was significantly earlier than those receiving saline only. But in case of peripheral nervous system disorder, hyponatremia is not commonly seen. But except in GBS, which is also an acute stressor condition, the incidence of hyponatremia in GB syndrome is reported about 21.5 to 48% of the cases. In our cohort of 581 GBS patients over a duration of 24 years, we found hyponatremia in 39.2% of the patients. Causes of hyponatremia in GB syndrome includes SIADH, renal salt wasting, hyponatremia post-IVIG. In our patient, we stopped IVIG. Despite that, he had persistent and longer duration of hyponatremia. Therefore, IVIG as a cause of hyponatremia in this patient was less likely. In this report, we can see that AIDP and Aman variant, both subtypes can develop renal salt wasting. All these patients had dysautonomia and was severely ill. And the hyponatremia was developed in the late first week and required 2 to 9 days for correction. Our patient also had dysautonomia, was severely ill, and AIDP. Along with that, he had high urinary sodium level, polyuria, and negative fluid balance. Therefore, we consider renal salt wasting as a cause of hyponatremia in our patient.
Thank you, Dr. Feroz, for elaborating on the cause of hyponatremia and the possible cause of polyuria and hyponatremia in our case. Coming back to our patient continued to have negative balance. He had polyuria, which lasted for about 6 weeks, after which it got corrected. This went hand in hand with the hyponatremia that he had. His sodium continued to remain low till about 6 weeks, after which it corrected. So this was correlating with the dysautonomia that the patient had. His blood pressures and tachycardia, dysautonomia also corrected by this time. Now we had 2 problems. One of hyponatremia and seizures. Second, of the high blood pressures that the patient was having. On one side, for the hyponatremia, we had to give salt and fluids. And on the other side, patient had dysautonomia and high blood pressures. And giving extra fluids and salt could have caused pulmonary edema and cardiac decompensation. Patient was advised tracheostomy, as we expected that the patient will require a prolonged intubation and mechanical ventilation. His mother was convinced only after the 3rd week, and we could go for a tracheostomy by the 3rd week of hospitalization. Patient was thereafter managed by careful suctioning, chest physiotherapy, and antibiotics were continued. And gradually, over the course of 2 weeks, patient improved. There was no recurrence in his seizures. The electrolytes were corrected by the 6th week. He remained afebrile. His counts normalized. His chest X-ray was also normal. The antibiotics thereafter were gradually de-escalated. His antihypertensives were tapered down, and TP's trials were begun after the 4th week. Patient was then shifted to step-down ICU and was managed there. 3 days later, patient developed fever, increase in his secretions, and a probable aspiration. We started empirically on meropenem and teicoplanin, and patient was again shifted back to the ICU and started on CPAP mode of ventilation. We did a chest X-ray which showed bilateral opacities, and to rule out any stress cardiomyopathy, we took the patient for an echocardiography, which ruled out any cardiomyopathy or a poor ejection fraction. So we continued with the antibiotics, to which the patient responded well. But his tracheal culture later came out to be positive for Acinetobacter, which was sensitive to colistin. However, by this time, patient was already improving, and we continued with the same line of treatment. Patient after 3 days was again shifted back to the step-down ICU and was tolerating TP's trials well. In this graph, we can see the trends of his respiratory functions over the course of his hospitalization. At the time of admission and during the first week, his tidal volumes kept on declining and he required intubation on the second day. Patient underwent a tracheostomy in the third week, following which he continued to improve and he was started on TP's trials in the fourth week. Thereafter, patient was shifted to the step-down ICU and patient probably had a VAP, due to which he was again shifted back to the ICU requiring some support of ventilation and responded well to the antibiotics and again continued to improve thereafter. He was finally decannulated at the 7th week of admission. And this is the photo on the day of decannulation, patient having better respiratory functions. Patient remained alert, cooperative. He was started on oral diet. He was engaged with cartoon videos because being a child, he used to often get restless while staying in the ward. His antihypertensives could be tapered down. He was noted to have reduced heart rate fluctuations, and he was gradually ambulated on a wheelchair. Patient was noted to have persistent facial weakness and lateral rectus palsy. His neck power improved, upper limb power also improved. At this time, patient used to have his meals using his hand, and we noted that he used to have some tremulousness and some ataxia. He had persistent bilateral foot drop and wasting. Due to the tremulousness and ataxia and the ophthalmoplegia, we considered a possibility of Miller-Fisher syndrome, which is a variant of GBS, as also already discussed, and we sent the antibodies for GQ1B, which came out to be negative. Patient was also suspected to have sensory ataxia. We repeated his nerve conduction study, which had, to our surprise, changed from the AIDP, which was there at the time of admission, and now was totally inexcitable. To discuss this transition of nerve conduction study, I'll request Dr. Rupali to please come up on the stage.
So far, we have discussed about the turmoil clinical course, and now I will be speaking about the neurophysiological part. Nerve conduction studies, they are the important part of the diagnostic criteria of GBS. Not only helps in diagnosis of GBS, but also in categorizing into demyelinating as well as axonal forms, which has a prognostic significance. So these are the various electrophysiological criteria. And in this table, we can see Albert's criteria and Dutch GBS study group criteria has the maximum sensitivity, and sensitivity further increases if the conductions are done around third week of illness. So coming back to our patient, at the time of admission, patient was having demyelinating type of neuropathy, as already told by Dr. Vishal, and on repeat conduction, even at 1 month and at 3 months, motor as well as sensory nerves were totally non-recordable. Overall, inexcitable nerve conduction was there. So why is this transition and what is the role of repeat conduction? From our previous experience, we have seen the yield of NCS was maximum if the nerve conduction study is repeated around 1 month, and it also helps in categorizing GBS as well as in its prognostication. So in this flow diagram, we can see transition of various neurophysiological subtypes from one to another, and maximum instability is found in equivocal types, which has the maximum transitions to either AIDP or AMAN. And in this table, we can see AIDP was the maximum at the time of admission and even remains so at the time of 3 months, followed by equivocal and AMAN varieties. And even at the 3 months, end of 3 months, nerve conduction became normal only in 2 patients, despite significant clinical improvement in overall 30 to 40% of the patients. So during communication of this paper, one of the reviewer has commented whether this transition is affected by treatment. So we proceeded with the prospective study involving 72 GBS patients. Maximum have received IVIG, and main subtype, electrophysiological subtype, was AIDP at the admission, followed by AMAN and equivocal varieties. And in this bar diagram, we can see the number of patients with normal or equivocal NCS at the end of 3 months was not different among the treatment arms, IVIG plex and NC, that is natural course. This is a flow chart. Sorry, this is a little chaotic diagram. but we can appreciate at the baseline, the AIDP were the maximum, and even at 3 months, AIDP remains more in number, and the maximum shifting has occurred from equivocal and Aman subtypes, and least shifting has occurred from the AIDP. So despite clinical recovery, NCS may not recover, and there is concordance and discordance between the groups. And also, if the patient is clinically improving and NCS is improved, or clinically static and NCS is static, that means concordant study. We have seen in nearly 50% of the patient, and discordant in the rest. So NCS and clinical recovery doesn't go hand in hand. And even at the end of 3 months, as we have seen in this previous diagram, only nerve conduction was normal only in 6 patients. So there is discordance in clinical as well as the neurophysiological recovery. And this discordance and concordance doesn't vary and affected by the type of treatment we have chosen, as p-value is only 0.17. GBS is not only characterized by motor weakness, but also by cranial nerve involvement, autonomic involvement, and sensory involvement. So what is the pattern of recovery of these neurological deficits over time, and what was the recovery in our patient? For that discussion, I invite Dr. Nagendra.
As we have already seen that the neuroconduction studies become normal only in a few patients, despite the good clinical outcome. These clinical outcomes are based on the GBS disability scale, which is largely based on the motor recovery. However, very few studies are there regarding the other symptoms of the GBS. So we have conducted a prospective study to see the recovery pattern in various other functions of the GBS. In a cohort of 42 patients studied over a period of 2 years, we found that at the end of 3 months, only 2 patients had complete motor recovery. By the word complete motor recovery, we say that the return of the reflexes in these patients with complete full power. And at 3 months, around 60% of the patients are functionally independent. The autonomic dysfunction recovered over a median period of 12 days, followed by the bulbar weakness over a period of 15 days, followed by facial palsy over 19 days, and sensory function over 20 days. The longest time was required for the recovery of the motor function. Subgroup analysis showed that the pattern of recovery is more prolonged in axonal variants compared to the demyelinating variants, particularly in bulbar weakness and autonomic dysfunction. This is our child at 6 months follow-up, where he is still wheelchair bound and having significant weakness and atrophy of the muscles. He is having persistent lateral rectus palsy. The tongue is atrophied and weak. Also, he is having significant ataxia.
जल्दी जल्दी करते रहो जीभ ऊपर लेके जाओ नीचे लेके जाओ
How can we prognosticate
Left side,
the mother about the further
right side.
recovery? Is this the end, or there is hope of still a further recovery in this child? Long-term follow-up studies showed that only 9% of the patients required aid at 5-year follow-up. And this is another long-term follow-up study which showed that the median disability at 5 years is 1, and it improved to disability score of 0 at 10 years. So the GBS patients may improve up to 10 years based on the remyelination pattern of the peripheral nerves. As we have seen that the autonomic dysfunction usually improves by 12 to 13 days. However, our patient had persistent hypertension, and also he had encephalopathy and seizure. So are we dealing with GBS, or we are missing some other link? Although the screening tests were repeatedly negative, with a stronger suspicion of porphyria in this patient with the conglomeration of the symptoms, we have sent for the genetic analysis. To our surprise, we have found that he was having a heterozygous mutation in RYR1 gene, which is corresponding to the congenital myopathy. And this is of uncertain significance. When we have reviewed that this ryanodine receptor is one of the molecules responsible for the, which is helpful in the excitation contraction coupling theory, and the mutations are implicated in congenital myopathy and sometimes susceptibility to malignant hyperthermia. However, our patient did not have any high temperature nor did he have rigidity. We also conducted an electromyography study, which showed that the potentials are neurogenic. So the presence of this mutation is a mere coincidence and did not contribute to the pathology of our patient. So with all this analysis, we have concluded that the final diagnosis is Guillain-Barre syndrome with severe dysautonomia. As rightly said, patients are the best teachers. No doubt this child has suffered a painful journey throughout his course. However, he taught us almost every aspect of the management issues of Guillain-Barre syndrome, including the clinical dilemma to the management of the complications. At the end, it is
Morning, Vishal sir. Are you coming on Monday?
at the end, it is very pleasureful to see a child recover to such an extent from the very severe course. We pay our thanks to the various departments who helped us in the management of this child. Also, we acknowledge the various alumni and current and past faculty and residents who are involved in the GBS research and helped us to maintain a large cohort database. Thank you.